Thank you for that introduction, and welcome to today's webinar. I'm Tony Magliocco, and it's my pleasure to be speaking to you today. And today I've selected a topic I think all anatomic pathologists and people who work in anatomic pathology are interested in, and that's quality. We're living in a world of changing quality demands, and I'm going to try to give you a highlight of some of the latest thoughts and advances in quality and application of quality to pathology. As a disclaimer, the presentation was prepared by me. The views are mine. The objective of this particular discussion today is to review the challenges of creating a system to assess the quality and consistency of diagnosis produced by individual pathologists. We're going to discuss how to set goals to improve processes, and with the ultimate target is improvement of patient safety. We're going to review how improved diagnostic accuracy also contributes to better outcomes. We live in a changing time, particularly in the United States. We're moving from a time of fee-for-service practice to thoughts that we really should be thinking more about the value of the money that we are spending on healthcare. And there's discussion that payers will be moving towards a value and a quality type of payment system. Consequently, pathologists need to be prepared for these changes. In addition, patients are becoming more empowered. This is partly due to the fact that they are becoming more responsible for their own payments in terms of co-payments. They are also becoming more aware of information through use of the internet and social networks as to what sorts of information is out there. And patients are also becoming less tolerant of error in that as they take more ownership of their own health and health care, they're less tolerant of error in the system. All of these things are creating a confluence of events for anatomic pathology. We have to remember that anatomic pathologists are not just microscopists or diagnosticians. They are fully trained physicians, they are medical consultants, and they are part of the care team. With many of the changes in therapy, pathologists are even becoming more important as many of the ancillary tests are now essential for the guidance of toxic and very expensive therapies, particularly in the cancer arena, where many cancer drugs are linked to companion diagnostics, and we are currently seeing an explosion in opportunities of trials and in immunotherapeutic treatments. Many of these treatments, especially things like CAR T-cell therapy, may end up costing as much as $1 million or more per patient per year. And a lot of this treatment hinges on the ability of a pathologist to give an accurate diagnosis and also to provide accurate ancillary testing. Now, it's problematic in that many reviews of pathology reports have shown errors frequently occur. Depending what you use as a denominator, in some high-risk specialties and esoteric areas, error rates can be as high as 44% of the time. And up to 10% of these errors may be serious enough to affect treatment. For example, if there's a staging error, a patient may or may not qualify for additional chemotherapy or radiotherapy. An error in the lack or omission of a companion diagnostic may also preclude a patient receiving a potentially life-improving therapy. This is an important area that pathologists need to be aware of, and an area of increasing concern regarding the quality of pathology practice. In a 1999 study, Johns Hopkins University found that 86 of 6,000 pathology reports, or 1.4%, contained errors serious enough to change the diagnosis, which could be considered critical errors. Now, where do errors come from if we really break down the process of anatomic pathology, there are three critical areas of the process. The first is pre-analytics. In pre-analytics, this is the preparation of the specimen prior to receiving it in the lab. And this is an area that is fraught with error in the sense there is opportunities to mix up specimens. Frequently, if an error occurs at this stage, it is very hard to detect and may require advanced technologies such as DNA typing to ensure that the patient is matched to the correct specimen. Oncologists and physicians sometimes are upset or resistant to stringent laboratory acceptance practices. However, it is really important to enforce these practices that specimens are properly labeled prior to submission to the lab. It is really for patient safety that these stringent acceptance requirements are in place. Also, in the pre-analytical condition, the management of the patient specimen is also very important. This involves two things such as warm ischemia and cold ischemia. This is the duration of time from when a tumor or tissue has been devascularized in a patient and then transported to the pathology lab prior to the time that it goes into fixative. This is a really critical time for living specimens, in that living specimens, as soon as they are devascularized, undergo physiological processes such as hypoxia and consummation of the glucose in the specimen, leading to rapid changes in biomarker quality and status. So prolonged intervals of warm ischemia can adversely affect the performance of critical biomarker analyses. So it is really important that these intervals be documented and be as short as possible. The next area is the analytical area. The analytical area is the machines and the testing process. Actually, the analytical area is the area that's probably best controlled in the pathology laboratory, as we are aware of this process and it's under the control of the laboratory in terms of the reagent systems we use in the machines. One important thought about this is that standard operating procedures must be in place, they must be followed, and they must be enforced. It is really problematic if FDA assays are pulled apart or tampered with or changed. So one has to be certain that the analytical procedure is maintained in a consistent way and that safeguards are in place to look at batch-to-batch variation and to document any unexpected occurrences during the analytical process. The next area where errors can occur is in the post-analytical area. In the post-analytical area, this is where a lot of scrutiny hasn't really been given, but in this area, things can occur in terms of, is the pathologist interpreting the specimen correctly? Are they trained to interpret the specimen? Or is there an error in diagnostic judgment? So errors can also occur in that particular area of diagnosis. Now, pathology practice hasn't really changed a lot over the years. Pathologists are medical specialists. They are focused on handling glass slides, and the information systems are not always the most efficient or even tailored to anatomic pathology practice. And it's been one of my frustrations in that the systems that I've used in my career for anatomic pathology were often really designed for clinical pathology practice, and anatomic pathology modules have been added on, making them cumbersome and not really suited to the routine anatomic pathology practice. Anatomic pathologists are also often overloaded in that specimens are easily delivered to them. They generally do not have limits on the number of specimens that they can see per day, and they're not restricted by intervals such as clinic times or opening periods. So anatomic pathology is extremely vulnerable to abuse through overuse or through increased volume. So I think anatomic pathologists need to be aware of this and need to think carefully, are they practicing in a safe manner, and that is the case material that they're seeing of a quantity and quality that they feel comfortable managing. And I think anatomic pathologists should speak out if they feel that they're practicing in a dangerous environment where they're overloaded or where the quality of the case material is not suitable to make an accurate and safe diagnosis. I know in some instances where diagnostic errors have occurred, pathologists have raised a defense that they have been overloaded and that had too much case material. However, in litigations, this did not stand, as the judge and jury determined that a pathologist is responsible for practicing in a safe manner, and if they feel that they're rushed, they should not really be signing out the case. So pathologists should be aware about this and be somewhat confident about their own practice ability and ability to manage case loads. Now, in anatomic pathology, reputation is everything. Really, that's all an anatomic pathologist has. So it's important that they maintain their reputation and that they build their reputation through a real focus on quality practice. How well are we doing in diagnostic pathology? So here's a CAP, ADASP summary of case review studies. So numerous case review studies were reviewed in this meta-analysis, and this was published in 2014. That we can see in the top here that all studies, there were 122 studies that were combined to look at these. Within these different studies, in surgical pathology, there were 89 studies. In cytology, there were 20 studies, and 13 studies covered both. In these studies, there is a look at what is the discrepancy rate and what is the major discrepancy rate. And we saw across all studies that the discrepancy rate had a median of 18%, with a major discrepancy rate of 4.8%. In surgical pathology, this was 6.3% for major discrepancies. And major discrepancies are usually defined as discrepancies that will impact patient care in terms of a change of diagnosis and so on. In terms of cytology, this rate was 4.5%. So these numbers are concerning in that you consider in every 100 patients that up to 6.3% may have an error of some type that influences treatment. And this certainly drives at centers like the Moffitt Cancer Center, where it is standard for us to review every external case that comes to the center for review of the pathology and for reassessment on tumor boards prior to initiation of new therapy. When we look at data from internal reviews versus external reviews, you see that in internal reviews, the discrepancy rate is much lower, about 1.3%, versus a 7.4% discrepancy rate in external reviews. And this probably is not unexpected in that this data comes from major academic centers, and that in major academic centers, you often see a higher external discrepancy rate compared to an internal one, mainly because these centers have an internal quality control process that removes major discrepancies before final reports are issued. Now, what processes have we put in place at the Moffitt Cancer Center? I'd like to share these with you so that you may consider them for your own practice. One of the first things that we do is every new pathologist that joins us at the Cancer Center, so we have 26 pathologists, and we are increasing our practice annually, so we add 2 or 3 new pathologists every year. So the first thing is a focused practice review of every new pathologist. So their scope of practice is defined. At our center, we have a subspecialty practice, so we tend to restrict the pathology practice to 1, 2, or 3 areas of practice. So you may have, for example, a breast pathologist who covers GYN, who may also do cytopathology. or a neuropathologist who also covers the autopsy service. So generally, our pathologists cover anywhere from 2 to 3 focused areas. Prior to them initiating, a plan is set out. So the section head will identify the area of practice and an interval of time. And generally, it's a 6-month interval of time. And during that period of time, after it's completed, the work of that pathologist is reviewed internally, and also the external work is reviewed as well, because in our practice, often cases are sent out to other centers for second opinions. We collect those and monitor them as well, as they can also be a check on our own proficiency through comparison of our diagnostics with those at other centers. If that goes well, that pathologist is cleared for routine work. The other thing we do is that we have a second expert review of all new Moffitt patients. So about half of our case material, we see 55,000 new patients each year at Moffitt, or I shouldn't say new patients, we see 55,000 unique patients every year at the Moffitt Cancer Center. About half of those patients come from outside. They've had diagnosis at other centers. So it is our practice to review the pathology of all outside material prior to initiation of therapy at Moffitt. Part of this process is that all new patients are presented at a tumor board rounds at Moffitt, and you can imagine this is very busy. We have 13 to 14 tumor boards that occur every week. So there are 1 to 3 tumor boards every day at Moffitt. They're a joint production with the clinical divisions and the pathology subspecialty experts that work together to present the cases. And typically, a tumor board, up to 30 cases may be reviewed over a 2-hour interval. At Moffitt, in our quality department, we have identified policies regarding consultations and managing errors. So this means if there is a significant error, that generally a second opinion is obtained within the department. And also we have a policy of notifying the care physicians that we have identified that error. In addition, if this error involves an external pathologist, it is our policy to notify that external pathologist as a matter of courtesy that we have observed a difference of opinion on a case. At Moffitt, we also have mandated the use of synoptic reporting to standardize discrete element reporting, and we use CAP synoptics. And in fact, that is one of our quality indices, whether these synoptics are being used and used correctly. Another thing we find valuable is that we have daily microscopy rounds. So at 1 p.m., the pathologists are able to attend a multi-headed microscope conference to bring case material, also the fellows and trainees. We have 12 residents and we have 7 fellowship programs. So these are dynamic events where cases are shared between the pathologists and discussed. And these are important opportunities, not only as a social occasion for pathologists to speak to each other, but a chance to share their opinions on challenging cases and to set their thresholds for atypia and other aspects. They're great learning events as well. We also have a process for formalized intradepartmental consultations where hard copies are issued, sheets are presented, and a pathologist will write out their opinion in hard copy, and these are retained for future reference. We have a monthly quality assurance meeting that is actually mandatory for pathologists to attend. Attendance is taken, and if a pathologist does not meet the minimal attendance requirement, they may not be eligible for promotions or bonuses, so this is how that is enforced. At these rounds, significant topics in terms of changes to policy are discussed, and key performance indices are reviewed. They're great opportunities for the whole team to get together to discuss aspects of policy and quality. And at these rounds, it's not just pathologists that attend, it's also the managers and quality managers are also in attendance, and departmental administrators at these rounds. Key performance indicators are essential to know if you're on track. Now, if you're trying to establish key performance indicators for your department, a key performance indicator must be meaningful and it must be relatively easy to collect. And you don't need a lot of them. They may be things such as the turnaround time on a frozen section, or the discrepancy rate on an external case review, or the turnaround interval for a pathologist to sign out a case, or the number of cases going out to an external center. These need to be easily captured, they must be reviewed, and targets also need to be identified. The target needs to be achievable, so in terms of if there's a deviation from the target, action must be taken to determine, is the target actually appropriate, or is the deviation an indicator of quality risk, and action needs to be taken immediately, or corrective action needs to be taken. Another rounds that we've instituted at our department are monthly morbidity rounds, where any errors or near misses are actually discussed. Generally, the pathologists involved are masked to make the discussion more comfortable. Cases are brought forward, and they're really intended to be learning events and events to really improve safety. In our department, we also created a safety committee. This committee works independently of the administration. So members of the committee do not hold formal positions in the department. They are there to review incidents and to make recommendations regarding how to improve processes within the department. And this is a really valuable committee that we use fairly frequently when a concern does arise. We also have a policy that every critical incident undergoes review as sentinel events to really ensure that it doesn't happen again and that we really learn from a mistake. A mistake is, as we know, only really a mistake if we don't learn from it. Every mistake is an opportunity to improve our processes and to really try to ensure that we have a continuous cycle of quality improvement. External proficiency testing and reviews are powerful. They are great ways to really ensure that your practice standard is in par with those of other centers. It's also useful in that it removes the personality from the review process, because it can be challenging when working in a close group of colleagues to be reviewing your colleagues' work. That it's more comfortable if the work goes out to an external center or to identified experts elsewhere, so that their opinions can really be looked at, and if there are issues in quality or practice, those can be addressed without that uncomfortableness of working with close colleagues and friends. And one tool that we use at Moffitt is incentive and bonus plans, where at the beginning of the year, certain mandatories are in place, such as the requirement to attend quality assurance meetings, and then targets are sent in terms of turnaround time or qualities of reporting, etc., and things such as bonuses and merits are tied to these as part of an incentive plan to improve overall quality. Now, review pathology by experts, I believe, is central to high quality practice, particularly in the complex area of cancer care. At Moffitt, we recommend that all cancer patients have a second opinion by an expert to confirm that there is a malignant diagnosis. And ideally, the second expert opinion should occur before commencing definitive treatments. So this is an important area to really focus on, and it's a safety measure. We have decided to create a subspecialty practice at Moffitt. We have the luxury of having a very large practice group of, as I said, 26 anatomic pathologists and 13 hematopathologists, and they're arranged into groups from anywhere from 1 to 5 subspecialty experts. And this is really essential to establish deep expertise in the subject area. And in cancer, it's a rapidly changing field in terms of new biomarkers, new challenges, new clinical trials. And so to really keep up on that, a subspecialty practice, I believe, is really the way to go. It enables a team-oriented approach and also creates bonds between the oncology team and the pathologists, where they develop a close relationship and trust can be as established. One of the problems is it's not as efficient as a general practice, where work can be distributed equitably and evenly across the teams. What happens in a subspecialty practice is that it can be problematic to justify to hospital administrators the need for additional subspecialty experts in areas of low volume. In addition, the teams may view their work as being different, so it's hard to measure exactly the work volume and complexity between different teams. For example, the teams that work on cutaneous pathology in general generate more RVUs per unit time than teams that work in breast cancer pathology. And this can create issues in terms of understanding equity and so on and distribution of work. And one of the problems is that the WRVU system over time has not really been adjusted to take into account these complexities of subspecialty practice. And in my opinion and that and others, that level 3 surgicals tend to be overweighted in the WRVU system, whereas high-level complex cases are undervalued. In addition, in a complex cancer center, subspecialty experts do significant work that is not captured by the RVU system, such as preparing for tumor board rounds, doing internal quality programs, and teaching. So there is very, very significant quality work that is being done that is not properly captured by the current workload systems, and this is problematic. There are other systems out there, such as the UK system and the Canadian systems, that are generally based on time measurements, and I think anatomic pathologists need to look more carefully at how our work is measured and valued so that we do get appropriate time and compensation to really do the important work that we do to maintain patient quality. I think some of these challenges are particularly acute in subspecialty practice centers, such as high complexity cancer centers, where all of the cases are of a high complex nature and that the work is really critical in assigning people to various clinical trials and to experimental procedures. So caution is certainly very important in these areas. Now, going to synoptic reporting, some thoughts on this. Synoptic reporting is useful in that it at least ensures completeness of reports. It's a memory trigger that enables a pathologist to remember to report all of the critical elements. However, it should be cautioned that it does produce a report that looks accurate. However, it may not necessarily be accurate. So completeness is one thing that is important. However, if incorrect data is entered into the synoptic report, clearly that is an erroneous report. So synoptics are useful in producing complete reports. The other thing about synoptic is that I've yet to find really a good informatics tool to facilitate the generation of synoptics in a convenient way in terms of providing the correct synoptic for the tissue specimen in place and also being able to auto-populate from aspects of the information that's already present. And this is an area, I think, for improvement in pathology informatics, really speeding up the acquisition of data so that pathologists don't have to re-enter data over and over again. And this would improve pathology efficiency. And I think there's a lot of opportunities to improve pathology efficiency through improvements in the informatics system. Now, returning again to the daily microscopy rounds, that this is a great social event for the pathologists and trainees to see the banter between pathologists about how they approach a case. They're daily, they're timely, they're quick. It's a great opportunity to get differences of opinion. However, one must be a little bit of cautiousness about it because a pathologist may not really have the time necessary to do a thorough and deep evaluation of the slides, of proper observation and careful thought to really render a truly independent opinion. So it's really important that when second opinions are done, that they be as independent as possible, not only just to protect the first pathologist, but to protect the consultant pathologist, and ultimately to protect the patient. The rounds are an opportunity for social interaction between pathologists and to build teamwork and trust. It allows calibration of calls so that dysplasia and atypia, one pathologist's opinion, can be shared amongst the group so that there is some standardization of that. It's a great opportunity to share knowledge. And however, one of the problems is that these types of rounds are not fully documented in a legalistic way or in a fully documented way. And maybe that's a good thing because it does allow for a sort of easier discussion. However, it should be remembered that this can be problematic and that these rounds maybe should not necessarily be referred to in the document as being, a key component of a thorough diagnostic review, simply because it's not thorough enough. And the pathologists that look down at these cases have not had the opportunity potentially to review the entire case material carefully, to look over the history of the patient with due care and with enough time. However, they are useful events to quickly review cases. Now, tumor boards are really at Moffitt. That's the central part of our activity as pathologists, and that's where the team really meets. And at Moffitt, the cancer teams are organized around cancer sites. So there's a head and neck team, there's a breast cancer team, there's a GYN team. And it's a great opportunity for the pathologists to fully interact with the overall care team. At these rounds, the trainees are there, the nurses are there, the clinical trialists are there, radiologists, radiation oncologists, surgeons. So the whole team is there. And these are great rounds for pathologists to really showcase their depth of knowledge and the thoroughness that they review cases. And I know that well-done rounds where pathologists take center stage are very, very valued by the oncology team. And they often comment about how great these rounds are, how much they learn from the rounds. Now, one aspect about these rounds is that one has to be careful that they're not overused, in that every case may not necessarily need to have the pathology shown at the rounds. Obviously, the case needs to be shown offline, or the case needs to be reviewed prior to the rounds. And generally, I like to run the rounds where really only educational material or points of contention are really shown at the rounds by the pathologist in depth. And this allows for the pathologist to educate and also to really discuss points of contention so that additional tests may be considered or additional procedures can be considered. Because one of the problems in these rounds is that time is limited and there may be a lot of cases that need to be reviewed. So certainly every case gets reviewed before the rounds, but the discussion, the time within the discussion, I think should be really tried to be focused on cases that require the input of people and that really require that intense pathology discussion. As I noted, a great occurrence to interact with oncologists and other members of the team. Sometimes the pathologist will get additional information. They may not know this patient had a previous renal cell cancer or that there was some abnormal finding on the radiology that can be helpful. So the additional information can be very important that the pathologist brings back from attending these rounds. In addition, the pathologist learns about what aspects of the case oncologists are really concerned about. The pathologist may have thought it was something about the histologic type was the biggest concern, but really find out it's a margin status that's particularly important to a surgeon. However, the caveat should also be noted that sometimes one pathologist will be presenting another pathologist's cases at these rounds in terms of another quality check, and sometimes disagreement does occur. And managing this it is a sensitive area because in terms of the overall team, openly disagreeing with a colleague at these types of tumor boards can create uncertainty within the department or lead to undermining a colleague's reputation. So I think a pathologist also has to be particularly careful about how disagreements are managed. typically in our department, what I advise is if there is a discrepancy, that be noted, that further work needs to be done. And out of courtesy and also safety, I think it's imperative that the pathologist gets back with the original pathologist. They review the case together so that a consensus opinion can be arrived. If a consensus opinion is not possible, in those cases, often we do recommend even a third pathologist become involved to try to really resolve the issue in the best interest of the patient. However, one also have to be careful about signing out cases by committee, that this may also not really be the best form of medicine. So really judgment is in place when there are disagreements, and that hopefully a consensus opinion can be arrived at with the best experts working together to get to that point. Another problem is that we don't always have all of the external outside material, and this outside material can be really critical for making the correct diagnosis. So it is imperative that as much of the outside material is obtained as possible, but the right slide may not have been signed, and et cetera. And this can be cumbersome, and also the pathologist should be aware, and also I think in a professional way, be courteous to the external pathologist so that when discrepancies do arise, that is an opportunity to really act in a professional way with that external pathologist to create a bond in terms of teaching opportunities, or there may be additional information that the cancer center pathologist has that the external pathologist was not privy to. For example, perhaps other biopsies were done at other centers, or additional imaging studies were done, and so on. And I think it's really important that as pathologists, we really work more closely as teams, and that for our colleagues who work in more remote or smaller centers, that we reach out to them to work, saying that we're really here to help, that we're here as an educational resource, and that we have pools of experts that can help with that practice that's occurring in the community. In addition, we've observed that sometimes the quality of outside material can be problematic, and that the expertise or staining quality may be not as good in some of the smaller centers, and that can also provide problems with interpretation. So one should be aware of that. In addition, the quality of external biomarker studies may also be variable, and sometimes this does demand that certain studies be repeated to ensure that the information is as correct and complete as possible for patients. Our Pathology and Morbidity Committee reviews all errors, near misses, and diagnostic challenges. And we try to do this in a blinded way to encourage participation, because we view these as an educational event as well as opportunities to learn from problematic cases and to share those problems among the team. As I mentioned, the Safety Committee was created to really review critical events and make recommendations. It's a formal process. Their recommendations are written up and go into a policy manual. The departmental chairs and administrators see these recommendations, and generally they're taken very seriously. The Safety Committee meets on a basis as required, so they may not always meet, or they may meet a couple of times a month if there are a couple of incidents that have emerged within a short period of time. So this is a standing committee. Term on it, I believe, is 2 years, so people rotate on and off the committee. And in general, we try to have people on the committee that don't hold leadership or administrative positions to make this committee as open as possible, and to make it at somewhat arm's length from the administration of the department. Now, informatics is an area, I think that's a problematic area in pathology, but a huge area, because every problem is an opportunity to build on. And informatics is really essential to monitor the quality of our practice, our volumes, our case materials, and our key performance indices. We found that the systems that we use are problematic in that they're very manual, it's hard to program them, and it's hard to extract the data that we really need. So I think this is an opportunity for informatics experts and developers of the future to create more user-friendly systems that have at their basis a quality standard. Because I think a lot of the informatics systems currently are built around billing and work tracking rather than quality metrics. So if we can move towards more of a quality metric system, I think this is a huge opportunity to improve informatics within pathology. And our own system at Moffitt is not really designed to extract this high granularity, and we rely heavily on manual extraction to really pull information we need to monitor our quality practice. The other use of an informatics system is to track outlying cases or workloads for pathologists, or to build systems for internal quality reviews where cases can be extracted and assembled into work plans for pathologists. So the informatics system, I think we'll see more use of it in the future, and it's a very, very important tool to really move pathology practice forward. Another area in informatics is digital pathology, and I think as digital pathology gains larger footholds, digital pathology will really be a huge opportunity for us to increase the quality of our practices through telepathology and through development of new diagnosis-assisted tools that run on digital platforms. So I think the future will be very bright integrating digital pathology with informatics. Now, some caveats and challenges. At a practice like ours, in some subspecialty practices, we may only have one or two experts in that area. So how can we review an expert? This can be problematic in that there are no other experts within the team that feel that they have sufficient expertise to review the subspecialty expert. There's the challenge of peer reviewing colleagues. How does one manage that? Particularly as colleagues may be former students, mentors, or even professional rivals. So this does create some aspects of potential conflicts and certainly discomfort. This can turn conflict into conflicts that can grow, that can be problematic, or automatic agreements that isn't really the right answer or the right process for ensuring quality. Also, is the team really keeping up with broader practice globally? So I think that this is an opportunity to really consider a proper external consultation practice in terms of finding other experts to share cases with that are at other sites. And I don't think there's easy approaches for this, although there are certain groups now arising looking at creating programs for external proficiency testing and quality testing. And these could be important quality initiatives of the future, where pathologists can share case material in a discreet way with colleagues, or an anonymous way, so that this professional rivalry and so on can be really put aside, and that we can really focus on quality practice. Now, moving on to other quality issues in pathology, anatomic pathology ancillary testing may be especially problematic by their nature. And anatomic pathology is really central to many companion diagnostic studies, particularly in solid tumors. Molecular biomarkers play a key role in personalized medicine for selecting therapy and for targeted therapies. Well-known examples are estrogen receptor and HER2 analysis in breast tumors, EGFR mutations in lung cancer, BRAF mutations in melanoma, and so on. Tissue is problematic to work with by its nature in terms of standardizing pre-analytics. And in anatomic pathology, we haven't had the history of critical standards that we have seen in clinical pathology. So it's somewhat of a new aspect to us as anatomic pathologists to really learn about how to quantitatively do quantitative biomarker analysis within our specialty, as we've generally been a qualitative specialty. Engagement in external proficiency testing can be very valuable. Here's some results from something called CIQC, which is a Canadian program to look at laboratory proficiency testing, much like CAP. In this particular study, a tissue microarray is sent around a number of labs, and the results are shown here in this matrix. So each row of this shows a single case. Each column is a laboratory, and the results going across show how the results occur at each lab. So, for example, on this top line, we see for this HER2 case that the results were either green or blue or white. So those results mean they were scored either 0 or 1 or 2. The cases where it's red means it was scored 3+, and we can see in this particular case that all of the labs had the same result. So there was excellent concordance. However, when we look at a result like this, it does raise concerns in that if we look at this particular case, some labs thought it was positive and some thought it was negative. Same in this case here, where some labs thought it was positive. So there's significant variation in the analytical and post-analytical interpretation of this one test. Remember, the same tissue was sent to all of the labs, and they all ran the same test. And if we look at this one column here, we see that this lab has a systematic, all of the results are being undercalled. So these tools can be very important in helping us standardize testing and also looking at recurrent error within certain labs. So engagement and proficiency testing is an important aspect. It also raises the concern that even standard biomarkers like HER2 and ER, we still have work to do, and that there seems to be important and often dramatic variation between laboratories. And most studies show between a 10 to 15% variation in terms of peripheral and central testing. And so there is significant work still to be done even in standard biomarker testing. Here's similar results for estrogen receptor, where we can see red is where positive, white is negative, yellow means the results were not able to be collected, and that we do see for some patients that the ER result is variable. Some labs will have a positive result, some will have a negative result. And you have to remember with estrogen receptor that this would direct a patient to up to 10 years of therapy dependent on this one result. And I think we really need to think about how do we improve these tests. These tests, there are multiple platforms, multiple ways to do these tests, and actually little research is really done on these established tests at how to make them safer and more accurate. So this is an area I think pathologists could lead in terms of developing better testing, perhaps better reagent systems, digital pathology, or more integrated tests could go a long way to moving this forward. What can happen in the pre-analytical phase? Now, as you remove a tissue from a patient, you have to remember that a tissue is a living system, that tissue becomes shocked once you turn off the blood supply. If it's in warm ischemia, you have to remember in laparoscopic surgery that sometimes a tissue like a colon cancer can be devascularized and left inside the patient for up to an hour prior to being separated from that patient and then transferred to the lab. So there can be dramatic intervals of warm ischemia that occur within a patient after devascularization. Now, in this study by Magliocco, there are a number of things that happen in the immediate intervals after a tissue is devitalized. Things happen. Glucose goes down, the temperature goes down, the oxygen goes down. If the interval goes longer, metabolic acidosis ensues, nutrients are depleted, and cells can die. Eventually, necrosis and apoptosis occurs. So there are physiological processes that are occurring during warm and cold ischemia, and these can impact biomarkers. So here's an example of certain biomarkers that are measured at different intervals in the same tissue as you go across time, and that you can see that some biomarkers actually go up when they're exposed to ischemic conditions and then go down. And mostly these are phosphorylation markers. So cell signaling is occurring, and it can be variable. So the conclusion about this is that, if you really want to look at cell signaling, you have to think about snap freezing or acquiring specimens right as soon as possible from within the patient. If you can't do that, the next best thing you can do is to really document what is the time of warm ischemia and cold ischemia so that you may be able to normalize results. The other approach would be to really look at internal biomarkers within tissue, perhaps things like alpha-1, HIF-alpha, or hypoxia markers that could be used to normalize tissue and to calibrate to overcome things that may occur with ischemic conditions and warm ischemia. As we learn more and more about cancer, we're now learning that cancer is a very dynamic disease. What we see here on the left is a representation of what's happening over molecular time in a cancer. So a cancer that starts as a single cell, as time goes by, will deviate and become more heterogeneous. There'll be subpopulations that come and go in that cancer. I like to say that cancer is a four-dimensional disease, so that there's heterogeneity within a tumor. And we don't even have standards about that. For example, with estrogen receptor measurement in breast cancer, should we just look at one section? What about a tumor that's 3 or 4 centimeters across? Should you be looking at 2 or 3 sections from that tumor? Certainly, if there's multiple foci of invasion, we should be doing the testing on each foci of invasion, and often you get different results. In addition, when a tumor becomes metastatic, it may also change. In breast tumors may become HER2 positive when they become metastatic. Perhaps new treatment modalities open up in those tumors as they progress. In this representation, this panel on the right also shows that once a treatment is given, so that if you give a treatment to a patient, that tumor will evolve. We know that if you give a treatment to a breast cancer patient that's ER positive, you may change that tumor to develop a new mutation in the estrogen receptor that now turns it into a tumor that becomes resistant to an anti-estrogen receptor agent. We also see this in lung cancers, where new mutations may arise in epidermal growth factor receptor, such as the EGF T790M mutation, that confers resistance to first-generation EGFR inhibitors, and that these patients now become eligible for a second-generation EGFR inhibitor. So it's worthy to keep in mind that retesting is probably indicated in patients that have a recurrence, in that we really want to treat the cancer that is now in the patient rather than the cancer that's in the bucket in the lab that was removed some time ago. In addition, there are new technologies that are arising, such as liquid biopsy, that allow us to monitor tumor evolution in real time. There are also some exciting developments in the area of adaptive therapy. If you were trying to eradicate a pest, such as a weed, in an agricultural field, the surest way to generate resistance is to use maximum tolerated dose. So now in agriculture, we know that suboptimal dosing is the best way to maintain resistance within populations. And there's thinking within cancer that using maximum tolerated dose may actually induce tumors to develop resistance, and that rather more pulsed and adaptive therapies could keep tumors in a quiescent state for much longer with much less doses of therapy. So one needs to keep, while this is experimental, it is certainly showing some exciting progress, and I think we need to keep our eye on that. A key component to enabling this in practice will be understanding the initial subclonality and structure of the tumor, and also developing tools that allow us to monitor tumors in real time, such as liquid biopsy. So challenges: undetected specimen mix-ups. These are often areas of concern that are hard to detect. Poor quality samples. You can only do so much, garbage in, garbage out. If you're seeing consistency, poor quality samples, you really need to look at your process. How is the surgeon obtaining the sample? How is the sample being managed or processed in the lab? We really need high quality samples to be able to do proper analysis. Pre-analytical variations. You really need to get a handle on this, on warm ischemia, cold ischemia. Try to minimize that interval, try to document it, try to figure out where your porters are going if they're missing, try to figure out where your specimens have been before they get to your lab. Really important to get a handle on that. Sampling error and heterogeneity. This is an area that requires further thought in terms of how much sampling is appropriate. Do we need to look at the metastatic clones? Recurrences probably should be resampled. Second, tumors in the same patient. You have to be really careful about this. Some of our patients may have multiple primaries. They may have a melanoma and a renal cell cancer. And when you're doing molecular testing, sometimes it's not clearly specified what tumor is being tested. One needs to be really careful that you keep track of which biomarkers are being done on which tumor. Is it a tumor before treatment or after treatment? And cancer patients are becoming increasingly more complex in that they may have multiple cycles of therapy, they may have relapses over multiple intervals of time, and they may have entirely new cancers that develop. And our information systems are not designed to really manage that complex information. So you need to be really careful when dealing with these complex cases. Developing strong teams. And leaders in pathology departments, it's really important to cultivate a culture of teamwork and to really put patients first and quality-centric, and to try to put our egos behind us and to really work together for the benefit of the patient, to create an atmosphere of trust where we don't use quality as a weapon against our colleagues, where we really try to learn from each other, where we try to show errors in a kind way, where we try to learn from them, and that we really work together as a team. So I think teamwork is essential, and cultivating that atmosphere of trust within a team is really important. Sometimes pathologists may be affected by undetected illness. They may be getting a cataract. They may be getting demented. They may be developing a drug or alcohol problem. And we need to be sensitive about that. Is there a deviation in their practice? Do they need medical help? Lack of expertise. And one of the biggest problems about expertise is that often you don't know when you don't have it. And I think this is where these PPE programs come in, or random quality checks or so on, is that you may be unaware that you have a gap in your knowledge. And so you don't know when to seek an external opinion because you may think you've got that particular area covered. So it's really important to have programs that test the experts as well. Information systems. We really, really need help from the information systems to make quality centric and to have systems that support quality programs. The explosion in new testing. Pathologists are central to this, and we need to take ownership of this. Over the last 4 years, there's been a dramatic explosion in clinical trials around immunotherapy. There are literally hundreds of new biomarkers that are under evaluation on the molecular and immune side, and pathology is right at the center of this whirlwind of activity. And I think pathologists can take ownership of this activity and become real leaders in terms of defining quality standards for biomarkers and inventing new biomarkers that have meaning in the clinic. Integrating multiple tests, and this is a huge challenge for pathologists to now think about. It's not just one test at a time, but we need to be true medical consultants. We need to be able to write integrated reports. We need to be able to advise our oncologists what is the right test to do next. We are the subject matter experts on tissue. And I think pathologists need to take their rightful place as being true consultants and be able to start writing more of these integrated reports that are really medical opinions that can integrate multiple biopsies over time, multiple types of molecular testing, and even give advice about what trials might be open or even what sort of additional testing is indicated in the future. So I think pathologists are really centered or at the center of the table here in terms of orchestrating the increasingly complex world of pathology testing and error and integration, and particularly when we work with our colleagues in more community-based centers that have busy practice loads. Our oncology colleagues often need help from pathology in selecting tests and integrating the results, because sometimes you will get different opinions from the same specimen. So a patient may have sent their specimen to 2 or 3 different external reviews, and now there's 2 or 3 differing opinions. It's really the job of the trusted pathologist, the one that the oncologist holds closest, to integrate all of that information and explain why was there a different opinion at this other center. You might say, well, they reviewed a different part of it, or they didn't have access to this particular ancillary test, so that one can then create a proper integrated report to resolve these conflicting pieces of information that are now more commonly arising. We also need more resources to support quality practice. Quality practice in pathology is not compensated. It doesn't generate RVUs, but it is essential to the reputation of the hospital. It is essential to the safety of the patient. And hospital administration needs to learn about the essential nature of pathology and needs to develop metrics to properly support a high-quality practice. So I think it's incumbent on pathologists to educate their administrators about the importance of pathology and about the tools that we really need to create a high-quality practice. And knowledge management, how do we manage all of this exploding knowledge? We really need to have tools in terms of things like webinars, in terms of publishing white papers, workshops, etc., to really keep our knowledge up to date, to exchange our knowledge. It's estimated that the world is short 2 million anatomic pathologists. The U.S. has the best staffed anatomic pathology in the world, and it's felt that we're facing dramatic shortages in the U.S. with increasing demands in terms of complexity, biomarkers, et cetera, increasing patient demand, and so on, that we really believe that there's a crisis emerging in terms of access to high-quality pathology. A lot of pathologists will say, oh, that's, we've heard that for years and years, and it's never really materialized. And I think one of the problems is pathologists aren't really the best advocates in terms of measuring our workload, in terms of proper staffing, in terms of quality tools. And I think as pathologists, we really need to take leadership on that to look at creating better workload models, to really focus on quality, and to have the resources and staff that we need for ideal patient safety. But many other countries only have 1 or 2 pathologists, and they're facing increasing demands from oncology and global practice of medicine. So the future does look like there will be a need for many more anatomic pathologists. I think digital pathology can help anatomic pathologists. Anatomic pathologists need to take ownership of digital pathology and really own that area. So huge opportunities for the future. Tools, total quality management tools, put those in place in systems. Improved informatics and real-time data. So one of the problems is knowing that you've made an error a year late. That's no good. We need to be able to detect errors before we even issue those reports so that we can correct it before it gets to a patient. So improved informatics, real-time data is essential to safety. Really need to do that. Telepathology can help in rare areas where expertise is spread around, or hard to access, can really put that in the hands of even community pathology practice, that they can easily reach out to experts in their field and to really share cases quickly and easily. Molecular diagnostics can improve the accuracy of our diagnosis and also increase the value of our diagnostics. But remember, the quality of these diagnostics also depend on the quality of the specimens. And pathologists are experts in specimen management, and we really need to take ownership of that pre-analytical component. We need to incentivize quality and value. I think some of the movements in payers are moving towards that. Again, pathologists should be spearheading that and leading it and encouraging it, that really allows us to have a safer practice. We need to teach our residents and fellows about quality and their role as leaders of the future. It really looks bright for anatomic pathology. And we need to develop and access the best-in-class experts and networks across the field. And there's so many new areas emerging. There's opportunities for many, many, many people to lead in different areas. So very exciting times. So in summary, in anatomic pathology, moving towards a quality model is essential and a great opportunity for pathology laboratories, particularly in anatomic pathology, an area that has somewhat been seen in the past more an art than a science, but I think the new tools that are coming in will allow anatomic pathology to become more precise and more analytical. I think pathologists understands quality and evidence better than any other specialty in medicine, and we really are experts in quality and can really take leadership positions in this area. Pathologists, many of them are introverted and they don't like leading, but it's really part of our responsibility to take on that leadership role, as to take care of that for our patients and also to make the data for our colleagues more accurate and safe. So I would like to acknowledge Leica for supporting this and to give me the opportunity to speak to all of you. I'd also like to thank the entire Moffitt pathology team, and particularly Dr. Centeno, who is a vice chair of anatomic pathology and who's a leader of quality assurance in pathology, and who has developed multiple quality initiatives in pathology at the Moffitt Cancer Center, including assistance with development of key performance indices, safety committee, morbidity and mortality committee, and on and on. So she's been really essential to our development of our total quality program. And one should remember, quality is a process. It's a continuing process of improvement. We always want to get better. We learn from our deviations and errors, and we keep moving towards a better standard. It's the right thing to do. It makes our practice safer, and it actually makes us feel better at the end of the day that we're producing a very high quality product that we can all be very proud of. So thank you for that opportunity, and please let me know if you have any questions. You can email me after the talk, and I'll be happy to have further offline discussions with you. Thank you.